We have the cardiovascular disease atherosclerosis, which is essentially the accumulation of lipid deposits. And these lipid deposits or plaques will degrade the arterial wall, and they can begin to obstruct the lumen or the opening of the vessel. And this can really have dangerous consequences when it comes to effective blood flow. Now, in thinking about the process of atherosclerosis, there can be small patchy thickenings that are referred to as atheromas, and that's what makes the walls of the arteries thicker and stiffer. So there is a change in form and function. And these changes are really initiated by damages or damaging events that take place within the endothelial cells. And when the endothelium is injured and we have dysfunctional endothelial cells, that promotes the accumulation of lipids, which can oxidize within the innermost layer. So here you have the outermost layer, the middle layer, and then there is the tunica intima, which is the innermost layer, which is expressly shown within this image. And that can result in an inflammatory response that can have a negative consequence. So we have these damaged endothelial cells, and these damaged endothelial cells will transport and modify something called a low-density lipoprotein, or an LDL, which delivers cholesterol to tissue cells from the blood. And what ends up happening is an accumulation of LDL, and the LDL oxidizes as well. That's going to damage neighboring cells, and through that damage, recruit macrophages. Macrophages, we've discussed, are professional eaters. They're going to come in and ingest, and they're actually going to become engorged with the LDLs through a process of phagocytosis. And then at that point, they actually get referred to as foam cells. Now, when it comes to the kind of next stage within this process, smooth muscle cells are going to begin to go through cell division, and that's taking place from that middle tunic or the tunica media, and it's going to start to deposit collagen and elastic fibers, and that's going to end up thickening the most intimate layer. And then we end up with our plaques. And so the plaque is going to consist of dead and dying foam cells, which over time can protrude and begin to invade the vessel lumen. And through having that protrusion into the lumen, we're going to start to decrease the amount of effective blood flow. And depending on where that blood is meant to go, that can have really harmful consequences. So just for vocabulary purposes, when looking at the right-hand image here, we can see a blood vessel that has plaque formation building up where the dashed line is. Then we also have something here that is called a thrombus. And a thrombus is essentially a blood clot, and that is kind of adding on to this decreased diameter of the lumen. And it's possible for a thrombus or a clot to grow large enough to completely obstruct a small vessel, or a piece of the thrombus can break off and then travel within the bloodstream and then end up as an embolus. And an embolus is essentially going to be a fragment of that blood clot that kind of wedges its way into a smaller vessel and is going to impede blood flow from that point on. So like thinking about an embolism, like a pulmonary embolism, that would be kind of an explanation, or at least of how that would have taken place. So in looking at this, there is a distinction between plaque formation versus a thrombus versus an embolus. And the embolus is not expressly shown here, but just to repeat, an embolus would be the result of a smaller piece of the thrombus, which is just a clot, breaking off and traveling through the bloodstream until it kind of wedges itself into a smaller vessel. And in doing so, it impedes effective blood flow. So cholesterol is an important factor when considering atheromas and the buildup of fatty plaques. And when it comes to cholesterol, this is a type of structural lipid. It's not oxidized for fuel as compared to other lipids. And the liver is capable of making a large percentage of cholesterol, and then the remaining cholesterol comes from our diet. And cholesterol is the basis for bile salts, which is something that's utilized within digestion of fats. It's also used for steroid hormone synthesis and vitamin D as well. Now, when it comes to cholesterol and transport from different locations, cholesterol is nonpolar and is going to depend on lipoproteins as a means to move from place to place. So when it comes to lipoproteins, they get classified into different categories based on their density. There are chylomicrons, there are very low density lipoproteins, low density lipoproteins, and high density lipoproteins. But when it comes to the overall organization of the lipoprotein, they're all going to have phospholipids, cholesterol, some type of thing that falls in a lipid category, as well as a protein, so lipoprotein. Now, when it comes to the various categories, the higher the proportion of lipid to protein, the lower the density. And that's kind of all that you need in terms of knowing the percentage breakdown of these different categories. You can also see visually that each of these categories differs with respect to size as well. And that's just more of an observation-based thing, nothing that I really need you to read into for testing purposes. Now, for very low density lipoproteins, they are produced by the liver and they transport lipids to adipose tissue. And it's at the adipose tissue where they are stored. And when these are removed from adipose tissue, they become LDLs. And LDLs are going to carry cholesterol from liver to tissues, so to places that need cholesterol, whether that's for membrane structure or for steroid hormone synthesis. Those are two of the common reasons why a cell would require cholesterol. And they'll absorb that LDL through receptor-mediated endocytosis and then digest that LDL utilizing lysosomal enzymes and then release the cholesterol for use. Now, high-density lipoproteins begin in the liver, and then the shell is going to travel into the blood. So it's essentially going to carry cholesterol from tissue to the liver. And as the HDL makes its way around, it's going to pick up cholesterol from places in which it finds it. And then the next time it circulates to the liver is going to remove that cholesterol and essentially eliminate it. So HDLs are used for removing excess cholesterol in the body. And so this comes into the concept of good cholesterol, quote unquote, versus bad cholesterol. And HDLs are considered to be good cholesterol because they're helping to decrease the amount of cholesterol that's found, which could potentially build up in blood vessels, whereas LDLs can, in essence, lead to an increase in the amount of cholesterol that's there if, when they are received at various locations and broken down, if they're not used effectively, they can have a harmful outcome. So here is one way that we can address plaques, and that's through something called a balloon angioplasty, which is essentially vessel surgical repair. And in this process, there is a catheter. That catheter gets threaded into the arterial wall. And then there's a balloon that's found at the tip of the catheter, and that balloon gets inflated. So you can kind of see it increasing in size. So there's the catheter, and then surrounding it is the balloon. Now, through the inflation of the balloon, there's pressure that gets applied against the atheroma, and that helps to widen the lumen. So that can help to resolve any issues with blood flow that would have resulted from that plaque. Now, the benefit to this treatment approach is that it's a little bit less risky than other surgical approaches. It's a little less expensive, and that can be a good thing. But when it comes to angioplasty, there is often restenosis, and this means that the atheromas, these plaques, can grow back in that site and re-obstruct the artery after a certain period of time elapses. So this is one technique that can help to resolve a plaque, but the downfall is that those plaques, those atheromas, can grow back. And so something that kind of helps to address that restenosis is the utilization of a stent. So the only difference here is that rather than just apply the balloon in order to exert that pressure and then remove it, here we have a balloon and a stent, and that gets inserted in the area in which we have that plaque buildup. And so the balloon still gets inflated, but as the balloon inflates, it's going to increase the size of the stent, and that stent's going to widen the artery. But the distinction here is that when you have balloon angioplasty in the absence of a stent, the balloon gets removed. Here the balloon is removed, but the stent stays behind, and that helps to maintain that space, maintain the lumen, and help to increase blood flow. So a stent is an approach or a modification to the balloon angioplasty that can help prevent restenosis, restenosis being the reformation of atheromas after a certain period of time elapses. Here we have the myocardial infarction, commonly referred to as a heart attack. And heart attacks are one of the main causes of cardiovascular deaths within the United States. And when it comes to a myocardial infarction, we're thinking about myocardium, which is going to be the largest or most conspicuous portion of the heart wall, right? When we were thinking about our different layers. And when there is damage to myocardium, that's going to impact the efficiency of heart muscle contractions. And the question then becomes, how can that occur? And so damage to the myocardium can occur when it doesn't receive blood. So we don't really think about the coronary artery supply when we think about systemic circulation in the pulmonary circuit in those examples, but it's important to include the heart in those specific vessels as a component of systemic circulation, right? The heart needs blood too, because the heart is really going to be depending on ATP to carry out this constant beating, right? So it's going to be something that is autorhythmic. It's not depending on anything. It's constantly working, and it doesn't fatigue. And we don't want it to fatigue. We don't want our heart to get tired in the same way that our skeletal muscles could. That would be really harmful for us. So myocardial infarctions really arise due to insufficient supply of blood to one part or more than one part of the heart muscle. And through this kind of deprivation of blood, the myocardial cells don't have the oxygen that they need to do the work that they need in order to effectively pump blood throughout the body. And as a result, there is muscle damage, which can result in necrosis or death of that tissue. And if there is necrosis or death, that cannot be repaired. And when it comes to the cause of this, it can be caused by a block in an artery, blood clots. It can be through atherosclerosis, anything that is going to impede effective movement to that region. Now, while we discuss this idea of muscle damage and necrosis and an inability to repair that damage, recovery is still possible if the damage was such that the heart can still contract in a functionally coordinated way. So something that may impair that aspect, such as discussed within the cardiac cycle, that would be harmful. But if it's something in which a small area of the heart is damaged, but we're still able to go through that coordinated mechanism, then recovery is feasible. Here we have an example of an aneurysm, and an aneurysm is the bursting of a major vessel. Now, when it comes to arterial walls, over time they can become thinner, and blood flow can cause those weakened walls to swell, and eventually, depending on the severity of that, can cause the vessel to burst. Now, if that vessel in question is something really significant like a cerebral artery, then the aneurysm event of the cerebral artery can cause bleeding around the brain. And from that brain bleed, there can be pressure that leads to death of that tissue. And that can result in a hemorrhage-based stroke. And so just in the same way that the heart is really dependent on sources for energy, same for the brain. And there are lots of mechanisms that our body has in place in order to ensure that both of those locations get what they need in order to continue functioning effectively. So something that impacts blood flow to the brain can have really significant effects. Now, in that previous example, we were thinking about the swelling and bursting of an artery. Now, in terms of damage to the brain, that can also occur through another mechanism. So essentially, anything that interferes with blood supply to the brain can lead to a stroke. So that can be through the blood vessel bursting, like the earlier image, but it can also be if the cerebral artery is blocked, and that blockage can occur through a blood clot. And it could be a blood clot that breaks off and travels to an area in which the vessel diameter becomes too small for it to proceed further, which is something that we talked about earlier. Or it could be a result of atherosclerosis, right? And so something that's going to change the lumen opening through the buildup of plaques. And so in both of these images, we're still thinking about necrosis or death of brain tissue. And, the timing of this can also impact the severity of stroke with respect to recovery, right? And so it doesn't necessarily mean that it doesn't necessarily mandate death as the outcome, right? And this would be another one in which the level of severity and the level of kind of long-term consequences can vary from individual to individual. So hypertension is often referred to as the silent killer because there are many instances in which you don't realize that it is an issue that should be treated until it's too late. And hypertension is a way of saying that there is high blood pressure. And this essentially can be a cause for a lot of things like heart failures, strokes, and kidney failures. And that's because through that hypertension, through that high blood pressure, the ventricles are working harder to expel blood. And the myocardium, which is largely responsible for those contractions, can enlarge up to a certain extent, but eventually it becomes excessively stretched and it becomes less efficient. Now, hypertension can strain the blood vessels, and that can tear the endothelium. And when there are tears in the endothelium, that can lead to atherosclerosis, like what was discussed earlier. And the atherosclerosis can then worsen the hypertension because the lumen has changed, and it can result in a really harmful positive feedback loop. So the plaques can constrict the vessels, and that can support conditions that can lead to clot formation. There are some risk factors, and I just put some here because obviously not all of them are listed, but age is a factor, sex is a factor, familial history, presence of cigarettes can be a factor. And when it comes to cigarettes, they can stimulate the myocardium to beat faster and can stimulate vasoconstriction. And through that vasoconstriction, that can promote myocardial ischemia. So that can promote less access of flow towards the heart. So we've already discussed just a little bit about inflammation as it relates to atherosclerosis, recruitment of macrophages, production of foam cells. So there is a relationship between inflammation and hypertension. And aspirin is something that can be prescribed as a way to inhibit inflammation, which can help reduce the risk of a heart attack and stroke. And when it comes to the role that aspirin plays, this is something that I have talked about in Bio 100 as an example of an inhibitor. And aspirin can serve as an inhibitor within a pathway that is associated with inflammatory factors. So aspirin inhibits inflammation through its role as serving as a inhibitor, and that is how it's able to reduce the risk of heart attack or stroke. So this is a nice way to connect the idea of enzyme inhibition and the impact that can have on catalyzing certain events now with cardiovascular function.